Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illnesses, typically those that would qualify for either palliative care or hospice care. Those are two separate services. I'm also a certified end-of-life doula through the International Doula Life Movement, an avid writer having published well over 500 healthcare articles, and an avid book author, having published books for hospice nurses, caregivers, holistic nurses, and my fellow end-of-life doulas. If you're new to this channel, welcome. Thank you for taking the time to visit. In this channel, we talk about things related to death and dying. After all, we're all going to die. Wouldn't it be better if we're prepared for what we're going to face? If these are topics that are of interest to you, please consider subscribing and hitting the bell notification below. I try to publish videos every Monday, Wednesday, and Friday. Occasionally, there'll be a gardening update or a house project video as well. The topic for today's video is going to be based off of a new caregiver book that I'm in the process of writing, currently in the illustration phase. This book was suggested, and I thank Dr. Andy Arari, if I'm not killing his last name too much, in the dedication section of this upcoming book. And before I go into the topic for today's videos, which is this is mainly for families for today's session, mainly for families. This could be for yourself, possibly, could be for a caregiver. But I want to talk about the subject of code status. We'll get into that in a little bit. But before we go much deeper, I want to ask you a question that I ask myself daily, sometimes several times a day. And that is, what are you grateful for? What are you grateful for? I believe that as one of the ways to handle many of the challenges that we have in life, loss, death, various life transitions, is to build resilience. To me, there are three pillars for building resilience. We focus on the third as a subset for what we do, what I try to do each video, and that is, what are you grateful for? Because in my experience, that if you're feeling sad about something and you start reflecting on areas that you're grateful for, it's harder to stay sad. I'm not saying that it's a cure-all. It's a fix-all. I just believe that it helps. What are you grateful for? So what I'm grateful for is I'm grateful for Dr. Andy. I still remember where I believe it was late November, early December of 2024. We're just talking last year, where Dr. Andy put on LinkedIn, and I'll put this in the description below, both the book that I'm going to be referencing as well as Dr. Andy's very short, concise endorsement for the book. It's my book on mastering hospice eligibility. And he stated that this book should be used by medical directors for different hospice agencies, by hospice admitting nurses, and by the entire interdisciplinary team. And when he made that endorsement, for lack of better words, of that book, which was typically in the top 10 list for books on hospice for nurses, for hospice nurses, it skyrocketed so that it varies. Some months it's number 2, some months it's number 3, but rarely does it go to number 4 for the books that I've written and published. So I'm very grateful for that. And Dr. Andy and I will have, he's also a book author. He's written a number of books. And we'll have conversations from time to time. And I still remember from August, my handwritten notes, we were on the phone. We're not always on the phone. Sometimes it's messaging. And he was saying, we were on the phone talking about palliative care, just to give a context, because I am struggling in Kentucky as it relates to palliative care. So I know I'm going to go on some rabbit trails, just giving you fair warning. But Palliative care, authentic palliative care, is supposed to be 100% based on symptom burden. Only symptom burden. It is to prevent the case of the person who has a chronic or terminal illness from getting to the point where they wish they were dead. I'm being very blunt. Palliative care is supposed to be just based on reducing the symptom burden, so the person who has the symptoms, who does not need to be terminal, can enjoy life and not wish they were dead. And in many states, in many geographic areas, authentic palliative care is not available. It's diagnosis driven versus symptom burden, or it's prognosis driven versus being symptom burden. And here in Kentucky, we get both. And as I say this, I want to be very clear because I'm talking about a gratitude point. I'm not trying to dismiss or down or demean or speak negatively. I'm just saddened that it's not authentic, because the palliative care in Kentucky will say it needs to be cancer, which is a diagnosis, and it needs to be life limiting, which is a prognosis. Kind of defeats the purpose. Well, if you're using life limiting, what makes you different than hospice? Just being real. But I'm very grateful for Dr. Andy. We're having this conversation about palliative care awareness. And in the middle of the conversation, Dr. Andy's saying, I really should look at writing a guide, a handbook, a guide that would help families go through the entire hospice journey from beginning to end. There's a lot of confusion for families. Confusion on code status, which will be the topic of today's video. Confusion on what is a crisis. I in my own hospice experience in Pennsylvania, still remember I'm on call and I get a call from my family member. I'm in York County, Pennsylvania. So if you know Pennsylvania, you want to bring up a map on Google Maps or however you want to look at your map, pull up a map of Pennsylvania. So I'm in York. York is right underneath Harrisburg. So I get a call from a family that's out past Shippensburg. So go look up where Shippensburg is on a map. And the wife's calling that the husband, who was not able to have a bowel movement, finally did, and it was very explosive, and the entire bed and everything is a mess. She's saying this is a crisis. I need to come out there to clean everything up, including him. I don't want to lessen the concern for the wife. I don't want to lessen the concern for the wife. That's not a crisis. It's a valid concern. She did need help. She did need help, but that's not a crisis. It was okay that she called, but it was not a crisis. And yes, she received help. But in terms of what is a crisis, my husband's at danger, or a wife, or uncle, or niece, or whatever the relationship is, the loved one who's terminally ill is so terminally restless and the medications aren't working and they're a fall risk, and I'm like all over them, and you're on a speakerphone and I could barely keep them down. I need somebody now. Or they're gasping for breath, they have air hunger, and they're on oxygen. I gave them morphine and something that's not working, or the nausea and vomiting. So Dr. and Andy, this is getting to the gratitude point. I know this is a long story before we get to the meat of this, but this is part of the reason for the book is, when you call hospice, and what's the realistic expectations. And so we're getting, like, he's giving me a laundry list and I'm taking notes during the process, and live discharge, navigating hospice, consents, and everything else. So that was back in August, and I did not have the time in August or even in early September to start the writing process. But I'm thankful for Andy, who gave me the incentive to write the book. And for any of you who've been paying attention to the book author writing portion of my videos, is what I will do as a book author is I'll come up with bullet points of what should be in the book, and it's raw. By raw meaning that it's not in logical order. It is literally a bullet point and a series of related ideas on the bullet line, or if it extends out past a line. So I'm just putting in what Dr. Andy wrote. I'm putting in my own ideas in there. And once I get an outline, I'll go and make it logical. How would this flow from the introduction to the chapters and the conclusion? And once I have that in terms of a very rough draft for a table of contents, what I'm going to be writing upon, then I'm going to go and then I'm going to craft the book cover, the front, because I want that to help guide me and give me encouragement. So every day, let me write something every day. And then as I'm writing, then I have to be flexible. To give you an example of that, and then we're going to get into the meat shortly. I don't want to drag this on, and I do appreciate your time. But to give you an example, one of my bullet items was the hospice levels of care. There are 4 levels of care. There's routine care, the most common. It's 95% of visits is the statistic nationwide, is routine care. That is scheduled visits, not appointment time, scheduled visits that hospice staff will come out, typically the nurse and the aide and so on, at different days and times, but not by appointment. So you have routine care as a level of care. You have continuous care as a level of care, general inpatient level of care, and respite care level of care. And as I'm getting done with that chapter, the writing of it, I'm realizing it. I need a chapter really dedicated to respite. Now, technically, you could argue there should be a chapter on inpatient, a chapter on continuous care. I did not want to belabor the book into being War and Peace, but we really need one on respite. So then it'll be a work in progress. So, but I do use the book cover once I get the table of contents drafted out. This is going to be my encouragement to write every day. So before we go too far, I do want to get into the meat of it, the meat of today's topic. Today's topic I want to talk to, again, this is for patients, caregivers, family members. And if you find this useful as an end-of-life doula, a social worker, a nurse, that's wonderful too. I want to talk about the brutal reality of co-status. When you are signing consents for hospice services, either then or shortly thereafter, when I say shortly, that's a vague word. Maybe it's not that day, maybe it's the next day, maybe it's not that week, but hopefully before your loved one passes, and if you're the patient signing your own consents, hopefully before you pass, you're going to be filling out a POLST, physician's order for life-sustaining treatment, or an MOST, medical order for life-sustaining, they don't put in the L. My autism brain goes, oh, well, yuck, sustaining treatment. And part of that is going to be, do you want to be full code? And I'll go into what that means in a moment, or DNR. DNR, do not resuscitate. And CPR, try to resuscitate. And when you talk about full code, that means every intervention possible known to mankind, including stuff that may be in the future, because hospice is a prognosis of 6 months or less. If the disease process, your condition, follows its normal course, you don't have to die in that time frame. So maybe 6 months from now, they have new technology and new methods. So whatever it takes to try to keep me alive, even though it doesn't cure your disease process. So that's full code. But when you fill out that form, it'll also have limited interventions, which means give me IV fluids or hook me up to a cardiac monitor, which, by the way, anytime that you pick anything other than comfort measures only, you're actually saying, in effect, put me in the hospital, and it will turn into full code, just so that you know that. So I'm not a fan of a la carte forms because they're very misleading. Because if you don't go DNR and comfort measures only, what you're choosing in effect is full code. It will turn into that one way, shape, or form. So when we talk about full code, and that means they're going to do everything to keep you alive, a lot of families don't realize a couple things. Number one, I need to talk about something that you need to absolutely be aware of, critical. The Center for Medicaid Services, CMS, governs every hospice agency in the United States of America. Does not matter what state you live in. Doesn't matter who is paying for insurance. CMS makes the rules. You do not have to be DNR in order to receive hospice care. If you have a hospice agency saying you can't be on our care unless you're DNR, they are lying to you, they're being unethical, and they're breaking the rules. They need to be reported because they're doing something that is unethical. It is wrong, completely wrong. You have the right to be full code. You have the right to say, I'm not filling out the POLST or MOST now at the time of consent. I'm a little bit too emotional. I need to think about it. And I'm not telling you what words to use. I'm just saying you don't have to sign that form on the day of admission. It's advisable, it's in your best interest, and it's in your best interest to fill it out before it's needed. When does the and we'll be on some rabbit trails as part of this, but I'm an educator and I want to fill in the blanks. When does this take effect? When does this take effect? The MOST or POLST, medical order of life-sustaining treatment, physician's order for life-sustaining treatment, aka your code status, takes effect when you code. Well, what does that mean? What does when I code mean? When your heart stops, like, they can't detect a pulse, you stop breathing, or it looks like you started the dying process. And when we talk about dying process, I need to be extremely clear, again, the educator. Dying is two phases: the transitioning phase and the active dying phase. The transitioning phase could be seconds, like, where did it happen? What? It could happen where it's so fast, you're questioning, did it happen at all? But it did. To several weeks. I've had 4 weeks and less. I've had fellow hospice nurses say they've had somebody 6 weeks. I would question if it was much longer, just because it's harder to tell that it's really transitioning if you go too far out. And then you have the active dying phase. So the code status would be in the active dying phase, not the transitioning phase. So somebody, like, if you imagine you're in a hospital setting, they're coding, and you see the doctors and the nurses and the aides running into the room, they're coding. They've started to actively die. They're not in the transition phase anymore. They're actually starting to actively die. They're starting to actively die. It could be having a heart attack, cardiac arrest, respiratory arrest. They're starting to die. That is when it goes into effect. The reason that I'm trying to be very specific is that there's a lot of myths when it comes to DNR and full code. And I'd like to go over that with you. And as we go through this chapter, I do want to give the disclaimer, couple disclaimers. One, education and entertainment purposes only. Two, this is the draft of the book. Right now, I'm going through illustrating the book. I still need to do a final review of the book. And even then, when the book is published, it is for education purposes. It does not replace medical advice. It does not replace you having a conversation with your healthcare provider. So in terms of putting that out there. So I do have an illustration here I do want to hit on because this is part of the concern I have, part of the reason why it's included in the book. No, you do not have to be DNR in order to receive hospice services. You don't have to fill out this form at all, even though it's highly advisable, because when you die, they're going to be asking, they're not even, let's not get into asking, what do we have going on here on the left? We have family members. I want to be very specific. The left is family members of both sides, left and right, family members. Person on the ground here, person in bed here. That's the dying or the dead loved one. On the right, the person is dead. On the right, the person is dead. They're in their own bed. The family's sad, holding the son or whatever that the gentleman is to the lady, holding her hand. The lady's dead. She is comfortable. She died peacefully. She is dead. On the left, family members. One of them is performing CPR. I want to be crystal clear, crystal clear. If you are on home hospice and your loved one starts to actively die and they are not DNR, you've not filled out the form. Now, just as an FYI, if you've not filled out the form, technically there's no order in place. You technically don't have to do anything. But if they're full code or you have CPR selected and maybe you put in limited interventions and again, the other things that you could put in, their CPR is selected. You're the one that's going to be performing CPR. The hospice nurse is not there. The hospice nurse is not there. Let's go on. But Peter, what about the case where this happens and the hospice nurse just happens to be there? Let me deal with that one. And I'm going to play it from the role of me. Let's say I'm the one there. And I want to be brutally honest with you. I want to be transparent with you. And as I state this, I did not look up Kentucky law. I'm going from Pennsylvania law. Being very clear, I come from Pennsylvania. I've been in Kentucky less than a year. I don't know the Kentucky law in this standpoint. I don't know all 50 states. I know Pennsylvania law. In Pennsylvania, as a registered nurse, I have the right to determine if CPR is futile, meaning that it's not going to make a difference. And I have the right to ignore a CPR order. Let that sink in. Registered nurses, doctors, and other healthcare professionals are not puppets and robots. We have the right to engage our brains and use our brains and follow our conscience. There are nurses that are out there, and I'm not saying they're wrong. There are nurses that are out there that are very regimented and they'll follow the orders regardless of what the outcome is. I'm not saying that's wrong. I shared many times for those watching this channel, you do you and I'll do me. I'm not going to judge you. Don't judge me. And if you do, I can't stop you. You be you. So I would look at the situation, and just so you know, I'm not saying this because I would not do it all the time. I still remember my case where I walked into a home patient. I know this is a rabbit trail. I walked into a home patient where I was hearing help, 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 and the person lived alone. I had the garage code. And when they weren't answering the door, went into the garage, and I'm hearing help, 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 and I went in, and they were on the living room floor, probably for 6 hours by their own estimates, and you got family members over, and we got the patient into their bed, and they were going into shock. They were going into shock. And I said to the family, I said, based on the prognosis, this is why to me, just as several rabbit trails wrapped into one, it is unbelievably important for hospice nurses to learn how to prognose. Can't stress this enough because it helps us help the family in terms of decisions. I knew that the prognosis for this patient was they were still in the 6-month mark. Their recert was coming up, recertification. I was questioning if they were going to pass the recertification, which means they might have more than 6 months. So I told the family, she's going into shock. If shock is not treated, she will die. Prognosis is going to change in less than 24 hours. Prior to this event, she might not even make recertification. She might have more than 6 months to live. What do you want to do? You want to keep her comfortable in her bed. We'll work with the provider on the medication orders to keep her comfortable. I'll be there the next day and the day after and the day after and the day after until she passes within my work schedule. Or we can call 911 and I'll be the one making the call and staying until they arrive and giving report. They chose to have me call 911. And this person is involved in several of my hospice journey stories of lessons learned as part of like hospice doesn't murder, hospice doesn't kill, hospice doesn't make anyone die faster type of stories. But when it comes to back to the CPR event, I'd have the right, based on the prognosis and based on everything else, to say that uh, no, I'm not. This is against my conscience and against my faith and against my judgment. And my prognosis is that it's not going to work. It's futile. I'm not going to be involved. So if the hospice nurse is present, just so that you know, they have the potential, depending on the state laws and the situation, to walk away. And that means that if you want it to happen, you're going to be the one doing CPR. You're going to be going an inch to an inch and a half. That's why ribs break. If you're not hearing ribs crack, you're probably not doing CPR correctly. It's not that you want them to crack. It's just an indication of whether you're doing it correctly or incorrectly. If they're not breaking, they're not cracking, you're not doing it correctly. Let that sink in. So you're there 100 to 120 compressions a minute, ribs breaking and cracking. Those ribs are probably puncturing locations. There is internal bleeding. There's a reason why most loved ones that survive CPR, it's a very violent procedure. If they survive CPR, they have chest tubes to take out the blood from all the internal bleeding that was caused with the CPR. It is a messy, violent procedure. And the reason that I'm making this face is because most people don't understand how violent this procedure is to the human body. I've done CPR in the hospital setting. That's one of the few settings where it has the highest survival rate is in the hospital. And you know what the highest survival rate in the hospital setting is? The highest survival rating for a hospital. We're talking about a patient room where they have 3 other people in the room, where at least one of them's a nosy, busybody. What are you doing with that? Who's coming in to visit? Whatever. Those are the ones that have the highest success rate because they're the ones going to be going, nurse, nurse, they're not responding or they're dying or something else going on. Somebody needs to come in here. The highest survival rate in the hospice setting is 20%. Out of 1,000 people, 800 people die, 200 people live. Yes, the CPR sucks that bad. CPR for success rates are dismal. In the nursing home setting, Survival rate, 5%. In the home setting, 1%. Why? That's one of the questions I'm probably going to have until the day I die, that nurses are required to have a CPR card, and why the American Heart Association learn CPR are going to save a life, when the overwhelming majority of the time, like if this is out on the street, treat it like the home, unless you witness the entire event from start to finish, and even then the success rate is low. If you're a passerby and they just happen to be out there and you perform CPR, 1% success rate. And for the family finding their loved one, and by the way, the reason that this is on the floor, you don't perform CPR on a bed. You need a flat surface. You have to get them off the bed onto a floor, or put a flat piece of wood underneath the bed so that the springs aren't going up and down. It is a very violent procedure with an extremely sucky, poor success rate. And so that you're aware too, when the success rate does happen, whether it's that 1%, that 5%, that 20%, the overwhelming 80% of them, 80% of the people who make it, whatever the ending number is, 80, take the ending number, 80% will end up in the ICU, the intensive care unit, for at least 14 days. At least 14 days. And out of that 80%, 80% of those will have lifelong debilitations. One of the books I recommend that you get, and I'll put it in the link in the description below, Between Life and Death, a gospel-centered guide to end-of-life medical care. I've been reading this. The doctor who wrote it, and yes, it's was it Dr. Catherine Butler, who wrote this, did a wonderful job going over the harsh realities that occur every single day, multiple times per day, in the hospital setting for families that are just, we have to do everything. And the hard part is, if they qualify for hospice, they're in a terminal state, which means they could die at any time. They have a terminal prognosis, which means 6 months or less to live. None of this cures the person. They still, if they come back at all, not only do they come back worse, I've yet to have a single case in all my years of hospice where they were grateful that CPR or they went to the hospital. I've had families where they've been years in counseling because of that decision. They thought they were doing the right thing, and then they're calling that they need grief counseling. They have complicated grief. Why did they do this to their loved one? And I'm sharing this to you now so that you have a chance to think about it before you go through this with your own living will, your own advanced directives. Again, the chest compressions, the mouth to mouth, and so that you're aware, the American Heart Association has moved away from that. The mouth to mouth's not as necessary. And CPR without an AED, that's that defibrillator that they could hook up. The success rate for just pure CPR without the AED is so low. Again, one of these days, it may not happen in my lifetime, they'll actually get rid of the silly requirement that nurses are required to have their CPR card and active CPR status, because it's like, why? Like, why are we putting our fellow human beings through this violence that rarely works? Allow us to exercise judgment 24/7. Allow us to use our brains. DNR. Do want to talk about this. DNR does not mean do not treat. And so that you are aware, there are doctors who don't understand this important concept. It blows my mind. It blows my mind. I've had conversations with doctors where, remember when we said this takes effect? When they're coding, when they're actively dying, that's when DNR would take effect. Let them die. That's what it means. DNR, they're actively dying. DNR, let them die. Keep them comfortable, but let them die. That's what DNR means. Does not mean do not treat. I've had doctors say, Well, we're not going to do the external oxygen, which is not always needed, by the way, for end of life. Or we're not going to do antibiotics, which, by the way, is a separate checkbox on the MOST, PLST. But we're not going to do that. They don't even look at the form. I've had doctors not look at the form. I've been the one saying, doctor, it's checked. The family wants it. Please. And I've had to argue and advocate so that you are aware doctors do have the right to exercise their mind too. Not saying they're wrong when they say that, but I have to advocate for the loved one. So if the family wants or the patient wants antibiotics, even if it is futile, I want to at least be a voice for them. And if the doctor says no after I've been the voice, at least I've done my job. So and just so you know, and this is where I do have to edit the book. Remember, I said it's draft. I took out chemotherapy because if they're on hospice, they're not receiving chemotherapy. So, but and granted, on hospice, you can go on with IV fluids is more rare than not. But hospice does not require just double checking my own. And yes, they can receive feeding tubes and dialysis, but keep in mind, as it puts in here, they're life sustaining. Life sustaining and quality of life are not the same thing. If you have a quality of life and your life is sustained, doesn't necessarily equal one, that one doesn't equal the other. Talk to people on dialysis that's going three or more times a week, sitting for 6 to 8 hours in a chair, pretty much tied to the chair, and then spending the days off recuperating as if that quality of life. Again, Grammarly Pro for those who watch my videos. Yeah, this is television. It's just this is just a beautiful, brutal reality. Where I'm going to come to a close on this is, let's say, Peter, according to our culture, according to my religious belief, according to whatever you believe, I'm going full code and or CPR with the understanding that if you put CPR, it will turn into full code. If you put DNR and limited interventions, it will turn into full code. I'm not a fan of a la carte, but you have CPR or limited interventions, and somebody called 911. We have to keep in mind this reality. I wish we lived in a world where it was like Star Trek, where we could teleport. I really do. And yes, I'd be the guinea pig to try teleportation. I know where I'm going if it fails. So here, in the cities, and I think 10 to 15 minutes, I was looking at different statistics when I put that there. But when I wrote that, put that there, oh my, when I wrote that, but I don't even know if that's like how close do you have to live to the fire department. But I still remember two cases. Both the one that lady that went into shock and I called 911. I had a case where a heart failure patient where he opted for palliative sedation, but I had a very, very, very conservative doctor. I'm conservative when it comes to finances, but when it comes to comfort, I'm liberal. Liberal for hospice means do whatever it takes to make them comfortable. Conservative is we're going to make these tiny steps for medication adjustments. And if they're suffering for hours on end because we're making these tiny steps, the doctors, I don't want to be Dr. Kevorkian. I had one of those doctors for my heart failure patient whose lungs was filling up with fluid, who wanted palliative sedation to be able to die at home. But the doctor would not allow me to go up as much as I wanted to go on the medications to have it work faster. And after 2 hours, the patient's like, call 911. And, if 45 minutes is not uncommon, sometimes an hour or longer. You have to keep that in perspective when you're looking at making the decisions that you're making. Again, at the end of the day, you're going to make your decision and no one's going to judge you for it. I'm just trying to prepare you for the reality that many families have faced over the years so that when you look at this, you can make a good decision for yourself. If you have any questions, please comment. This is a non-judgmental channel. I platonically love everyone that I try to serve. I appreciate you and I thank you for your time. God bless.